Thank you so much, Jordana. I just want to say a few things before I get started here. First of all, I didn't rehearse this today because I wanted to come off as authentically as possible, so it might be a disaster, it might not, we'll see. I also want to thank Lonnie Regenbaum for the beautiful introduction this morning. Thank you so much, and to the team at the Autism Research Center. I also want to say what a privilege it is to be here. I have my whole master's committee presenting today. I had Emily Hotez this morning, Lonnie, Sandy, and Heather, and I just feel very honored to be up here and to be a peer now, which is really cool. So I will be presenting a little bit about my research for my master's, as well as a couple practical tips. So my thesis was on medical residents' thoughts of autism education. And then I'm also going to be talking a little bit about active participation in medical care for autistic individuals. So this is me as a 6-year-old when I was just diagnosed with autism. I was diagnosed at age 6, which led to barriers in the healthcare system, particularly with regards to communication in the healthcare system. So as a primary investigator of this study, I, Nicholas Piroddi, bring a unique perspective shaped by my personal journey growing up on the autism spectrum. My experience as an autistic individual has led me to face barriers in the healthcare system, again, like I mentioned with communication. I've also experienced ableism in academic settings prior to starting my master's in pediatrics. These lived experiences have significantly influenced my current academic pursuits and research interests, and it's why I'm standing up here today. While I do believe my personal lived experience provides valuable insight in conjunction with my academic experience throughout my master's, I am cognizant that I need to conduct research with academic rigor and impartiality. As an autistic researcher and advocate, one of my goals is to bridge the gap between the lived experience and scholarly inquiry, offering a nuanced perspective that enriches the overall understanding and autism education. I acknowledge that my positionality may shape the research process and interpretation of findings, especially in a qualitative context. So there are kind of two main barriers that I've noticed in my literature review regarding autism care landscape. And the first one is access to timely diagnosis. The longer the waitlist times, the longer and delays in accessing evidence-based resources and interventions during critical development periods are. In the IPASS clinic, for example, was about 19 months waitlist before the COVID-19 pandemic, and through some personal communication with the manager, I've realized that it's close to 24 months now, which is a little bit disheartening. And it's even longer for older kids. I don't have the exact stats on that. And there are several factors that influence quality of care, including the availability of evidence-based interventions, the expertise of healthcare providers, and the coordination of services across healthcare and community settings. Further, factors such as race, ethnicity, culture, socioeconomic status, sex, and gender identity also contribute to health disparities regarding quality of autism care. So the overarching challenge really is we need to increase community capacity in Canada. And understanding the prevalence of autism is crucial for informed healthcare planning, resource allocation, and determining public health policy. This slide shows the challenges in Canada with respect to the landscape of autism care, because there may not be a significant number of trained clinicians to support the following, being the changing landscape of autism with respect to diagnosis, the high prevalence of co-occurring conditions, so that could be like mental health conditions like anxiety, depression, or things like ADHD, or even physical health conditions like GI issues or epilepsy or sleep disturbances. Transitioning in adulthood is another big thing. Like I know there were some questions this morning around like what kind of research is being done for adults. That's a big gap too. And also caring for autistic individuals in rural communities. That's a call to action, I guess. So one path forward is to incorporate more training on autism care into medical education, particularly at the residency stage. But to our knowledge, no study has evaluated the pediatric residency training programs in Canada to determine where the learning needs and gaps in autism care are. So that's kind of where I come in. So my research questions are really, what are pediatric residents' current perspectives on providing best practice care for autistic patients, and I use the word patients intentionally here because it's the language that the participants of the research used. So I use the word patients very intentionally there, just to make that clear. But what are their roles? The role of providing best practice care for autistic patients, including the role of the pediatrician on the care team, and also the learning needs of areas of improvement for pediatric residents surrounding autism care in the medical system. So we had 12 participants, all identified as female, from UBC and U of A. They were all residents at different stages in the residency program, and we did a semi-structured interview process. We used Thorne's interpretive description methodology, which identifies themes and patterns from subjective perspectives while recognizing the varied experiences of interviewees. It's not intended to be completely objective, but instead serves as a framework for clinically relevant research and practicality. And then we did a reflexive thematic analysis to determine themes surrounding providing best practice care and gaps in providing best practice care. So we kind of came up with 7 themes under 2 categories. So category 1 was on what are the actual best practice care guidelines according to residents. And the first one here is, and I'm going to delve into each of these in more depth, but I'll just kind of give a brief high-level overview here. So theme 1.1 is, it is important to meet a kid where they're at. So that's all about flexibility and optimization of care. Theme 1.2 is families will respond differently. So that's really looking at family understanding, education, and kindness towards the family. And theme 1.3 is that it takes a team. Coordination with multidisciplinary professionals is important. So again, these are from the residents' perspective. These are not my personal opinions, although I do agree with them, I will say. And then category 2 is that pediatric residents outline barriers to providing best practice care for autistic patients in outlining learning gaps in their medical training. There's 4 themes in this category here. The first one being autism is in many ways more complex. And that really comes down to pediatric residents feel like they're not adequately trained to take on autism. Theme 2.2 is what am I actually allowed to do? And this brings up a sense of real confusion in terms of diagnosis and management of autism. Theme 2.3 is what I learned may not be applicable to my practice, which is essentially pretty self-explanatory. But one example that would be like in an urban environment, if you train in an urban environment, how can that be applicable to a rural environment? And also even in an urban environment, there's long wait list times, so not everything is applicable. I see Jordan laughing back there. That's totally throwing me off. And then theme 2.4 is I see myself playing a quarterback hub role. So despite not being taught well, residents see themselves playing a role in long-term care. And again, I'm not a football guy at all. I don't know if you can tell, but but essentially it's like that medical home model where I just threw myself off now. But it's not just a medical home model, which I'll get into a little bit more when I talk about that theme. So pediatric residents emphasize that autism is a spectrum and that healthcare providers should adapt their approaches based on the individual needs of each child. This sentiment aligns with the principle of patient-centered care in medicine, which advocates for tailoring healthcare to the individual characteristics, needs, and preferences for each patient. Again, there needs to be a stronger emphasis on flexibility in training, because like the training is pretty focused on rigid diagnostic criteria and standardized methodologies for assessing autism. And residents called for more flexibility in their training. Theme 1.2, so families respond differently. Again, this is pretty self-explanatory, but it is about family understanding and education. Every family will respond to autism very differently. Some of them take it as a grieving process, for example. You don't know what a family is going through. But also what came up a lot was kindness towards the family and showing kindness during this, because it can be a really tough time for a family or for parents or for caregivers as well. And I will share that some communication plays a big role here. A personal story of mine is when I was diagnosed at age 6, my parents were told a lot of horrible predictions about me, like just about like not having friends, not having a job, not being able to finish high school even. And like the point is like, I'm not trying to say, look at me, I did a master's, but look at me, I did a master's, you know, like, but that's all to say is that goal setting is so important, and what clinicians say actually does hold a lot of weight for many people, you know? That's my personal story. And theme 1.3 is that it takes a team. So I have a table here. I directly asked all my participants who is involved in the care for autistic children. And there's a couple things I want to point out here. The first is that above pediatricians, which had 6 of the 12 people respond, speech language pathologists, occupational therapists, and behavioral therapists actually come above pediatricians. Now, pediatricians did not directly say that pediatricians should be involved because they didn't know how they fit in that long-term care. But also look at the breadth of participant or healthcare professionals involved in the care of autistic children. Now, I'm not saying that every child needs every single one of these, but it is important to be flexible with care, and it does really take a team to provide best practice care, which again is very hard when you look at rural communities, for example. And then moving on to category 2 themes. So theme 2.1 is that autism is in many ways more complex. Medical education tends not to capture the full spectrum of manifestations and co-occurring conditions. The reality is when you meet one person with autism, and I'm sure everyone in this room knows this, when you meet one person with autism, you meet one person with autism. And that's not even accounting for things like the co-occurring conditions and I'm intentionally using co-occurring conditions and not comorbidities. I just want to make that clear. But it's not accounting for all the co-occurring conditions that may take place concurrently with autism. There is a disproportionate gap in how much time is spent on developmental pediatrics and training compared to the quantity of children seen in real world practice. So some of the stats say that in a general community pediatric clinic, about 50 to 60% of your clinic is going to be behavioral and developmental health. They get 4 weeks of this in residency in a 4-year program at some places. U of A, they have 8 weeks, but most places they get 4 weeks. That is not proportional. And then some areas residents feel uncomfortable with include pharmaceuticals, community services, and aggression, managing aggression. And I want to say with pharmaceuticals, I'm not an expert in any of these, but I do want to say like there are a lot of misconceptions that there are medications that can maybe cure autism. It's more so about the co-occurring conditions. Role confusion can have significant implications for patient care as well. While healthcare providers are unsure of their responsibility, it can lead to delays in diagnosis, inconsistent care practices, and insufficient support systems. Residents note that they don't want to overstep boundaries regarding, vocabulary, perceptions, and resources. Kind of gatekeepy, if you guys can't tell. And then theme 2.3, so there's a disconnect to what is being taught in residency compared to practical applications. So some examples are that multidisciplinary sites are not always feasible, and this is due to like multidisciplinary sites are not feasible in like a rural community per se, and also because the wait lists are very long. Like I said, they're up to 24 months now. And increasing community capacity through case studies and didactic teaching. I know Dr. Reagan talked a little about Project Echo this morning, like incorporating case-based discussions where everyone is teaching and everyone is learning might be a way forward in like case-based discussions in residency. And then the medical home model, so that's the quarterback hub role. It's really that long-term, and another thing I want to mention with the medical home model is that long-term care is not focused on as much in residency as diagnostics, but everyone that I've talked to, whether it's through this project or else outside of this project, has said they want to play a role in long-term care. They just don't know how. So this is an overall schematic of how some of the gaps, which are represented in blue, because I also did a content analysis of the gaps, which I'm not going to go into too much depth here because I don't have the time for it, but they fit in with the themes, which are in green. So I'll kind of go over a few of the gaps here. I'm just gonna, so we note that the overarching goal of pediatric residents is to provide better long-term care, which is represented by the first gap on the top left. This lack of focus on long-term care relates to the theme of wanting to play a quarterback and hub role, which is also associated with the gap of the management of the co-occurring conditions. This gap is also associated with the theme of being unclear applicability and scope of practice, which also relates to the lack of role clarity of the gap, connecting to the theme of what am I actually allowed to do? A prominent gap was that the teaching on autism is actually there needs to be more teaching outside of development. So for example, including case studies where autism is just a factor, it's not the factor, right? Connecting the theme to role confusion to autism being more complex. So autism is just a way of, it's an identity for people, So this is due to a gap of lack of exposure to pharmaceuticals, community services, and support systems as well. So the middle blue gaps connect category 2 themes to category 1 themes. It takes the team as connected to playing a quarterback and hub role, as there are communication concerns in the community, and also applicability to practice based on practicality. So a lot of multidisciplinary professionals find it hard because everyone is so busy to talk to each other, which is definitely an issue when it comes to caring for anyone. What am I actually allowed to do is connected to families responding differently as residents feel they need more exposure to assessments, and autism is in many ways more complex. It's connected to meeting the child where they're at as residents feel autism is layered in complexity. Finally, connecting category 1 themes together is all about communication. Communication with allied healthcare professionals takes a team to families responding differently, while it's connected to meeting the child where they're at through communication with family. And again, this is a lot of information on the slides. I'm happy to dissect a little bit during the Q&A period. But the point here is that there's a lot of gaps that residents noted that connect to the theme. So it's not like I was just pulling themes out of thin air. There were gaps to back it up. So one of the key findings from my research is that many residents feel they have not adequately been trained in autism care. That was theme 2.1. This means that autistic individuals often be the ones educating their providers on what works best for them. Another issue is role confusion, which was theme 2.2. Many residents are unsure of what they're allowed to do regarding autism diagnosis and care, and some might hesitate to provide necessary accommodations or refer patients to the right resources. So self-advocacy becomes crucial in navigating the system. It helps ensure autistic individuals receive the care they need despite the gaps in provider knowledge. So common challenges autistic individuals may face include like sensory sensitivities, difficulties expressing needs, and providers lacking autism-specific knowledge. Advocating for oneself allows for better communication, appropriate accommodations, and a more collaborative approach to care. So how I approach this, and this is going to be totally off script, but I did the 3 themes from category 1 and came up with some strategies for effective self-advocacy. These are strategies that I've used. I just want to emphasize that doesn't mean that they're like a Bible or anything. They work for me, but everyone is different. So meeting the patient where they're at. So before the appointment, a strategy could be writing down key concerns and priorities ahead of time so you feel prepared going into your doctor's appointment. Identifying sensory and communication needs and request accommodations ahead of time is also something you can do, like phoning the office ahead of time. During the appointment, you can use your communication tools and clarify any expectations that you have. And then after the appointment, you can always request written instructions or a follow-up email to review after you have time to process the appointment. Because that's a big thing for me when I'm at the doctor's office. And I have a great doctor, by the way. But I request like a follow-up email, for example, because I don't have the capacity to process everything in a doctor's appointment when I'm going in for so many concerns related to autism or not. Families respond differently. So really what you can do here is bring a trusted advocate, whether it's a family member, friend, or support person who understands your needs. And if caregivers are involved in your care, ensure that they understand the healthcare plans and can assist with any follow-up. So they're allowed to ask questions too, as long as you give consent. And then finally, it takes a team. So you can ask for referrals to specialists such as OT, speech therapy, mental health services, and other physicians such as psychiatry, for example, and use a hub approach by ensuring providers communicate with each other where possible. So this ties into theme 2.4 as well with that medical home model. You can advocate for people or for healthcare providers to communicate with each other as well. And then, so to summarize, healthcare providers may not always have the right training, so self-advocacy is important. And I feel really bad saying that because I'm in a room with so many people that are so wonderful in the autism field, but it's true. There are people who, the training isn't great per se. Effective strategies include preparing for appointments, communicating needs clearly, and using a team-based approach. Supporting networks and self-advocacy tools can individualize and can help individualize the system more effectively. And I encourage everyone to take an active role in their healthcare and to support others in doing the same. Other than that, that's all I have. Thank you for your time.